Hi, back with another session here. Here I'll discuss with you about the history taking, and mainly I'll take here the antenatal history part. Okay, so for a history, basically we are taking antenatal history. We should stick to a format so that you know what all has to be asked and in what order you have to ask to the patient. But before starting my topic, I'll better discuss with the trimesters week wise. So from 1st to 13 weeks is your first trimester, from 14 to 27 weeks is your second trimester, from 28 to 40 weeks is your this third trimester. Okay, so you must know these week wise trimesters. Then starting with our topic, history taking, antenatal. So first thing is identification details that you should know. Sometimes examiner will ask you that why the age is important, why you ask the age, why you are asking occupation, why you are asking address. So you must know these things, like why you are asking. So I'll take these points on the stress, like name. Why name is important? Why you are asking? Because when you address the patient by her name, she will feel nice and you will develop a bond with her, rapport with her. Like for identification and for communication, the name is important. Then age. Age, like certain diseases are age restricted, age related, like if the patient is less than 18 years of age, that means teenage pregnancy. Teenage primary patients are at a high risk of developing hypertension, of developing anemia, of developing malnutrition, and CPD. So that's why less than 18 years, this age is important for us. If she is more than like 35 years, she will be at a risk of developing hypertension, diabetes, and like she is having higher risk of getting some genetic diseases, congenital anomalies in the baby, or like risk of abortion is there. Abortion risk are really high in this age group. Then the next thing is education. Education is important, and along with that, socioeconomic status is also important while taking history, because she would be able to understand your counseling, her socioeconomic status, like how would she respond to your advice you are giving to her. Also, it will help you to know a proper language, like in which language you have to communicate with her and in which language she is comfortable. So socioeconomic status for counseling and for communication language, the education is important. Then occupation. Occupation is important to decide a plan for her, like further plan. Like if she is a laborer involved in some construction work, or she is lifting some heavy objects, so she will be at a risk of developing preterm labor. Okay, maybe abruption, APH, abruption placenta. Okay, suppose she is a some software engineer. If she is some software engineer, so she will have to like face computer for a long time, so long sitting problem. For long sitting problem, there are increased risk of DVT due to immobility. So occupation is also important. Now then, address. Address is important to describing the status of disease in a specified population. For distribution of diseases, you should know her address. Like the high, if she is living at a higher altitude, there will be a less oxygen saturation there, hypoxia, and leading to what? If higher altitude, it will lead to IUGR. So the address is also important in that patient. In all the patients, you should ask these things. Then after the identification details, so the main thing you should ask is you should know is identification details. Then comes parity index. So parity index is GTPAL, used to create treatment plans for pregnancies. G stand for gravida, P is para, living children, and abortion. So gravida, I think you all know the gravida, para, living children, abortion type of things. I don't need to like define everything. So next thing is LMP, EDD and period of gestation. You must know the LMP. You ask the patient the LMP, but sometimes they are not like very sure for their LMP. In that cases, the first scan, which is a dating scan, will help you in knowing her EDD. From LMP, you are able to like calculate EDD and also period of gestation. So LMP is important. The next thing you will ask is chief complaints. Chief complaint should be in a patient terminology. Like if she is saying 8 months amenorrhea, you should say 8 months amenorrhea. If she is saying 36 weeker, then you should say 36 weeker. But it is quite rare, not rare, but it is quite less that less often she will say that I am 36 weeks, 35 weeks. Mostly they will say 6 month, I am 8 month pregnant. So you have to say like that. Along with that, you have to explain all this complaints in a chronological order. Like if she is complaining of having pain for 2 days, so you have to say she is having a complaint of pain abdomen for 2 days and suppose leaking PV for 1 day. So in like that you have to explain. In the history of present illness, you have to elaborate the details. Okay, so elaborate the negative history also and describe the complaints in details. Like if the pain started 2 days back, then you have to say about the pain. Like pain is not constant or like constant, regular in onset or something like that. So you have to say like pain is regular in onset, its frequency and intensity increasing, it is radiating to back, like that. And in negative history you have to say like no history of leaking PV, bleeding PV, or no history of burning micturations, no history of decreased fetal movements. Like that you have to elaborate the negative history. After the negative history, I'll take this thing, a history of present pregnancy. So how history of present pregnancy is important. History of present pregnancy, you have to say first trimester, then second trimester and the third trimester. So first trimester is from conception till the 13 weeks. So what are all the points you have to ask? You have to ask if your conception is spontaneous or any fertility treatment you have taken, any ovulation induction you have, because if ovulation, in case of ovulation induction, like in the PCOS patient, generally we are giving them ovulation induction treatment. So in that case they are at increased risk of developing GDM if the pregnancy is ongoing, otherwise high risk of abortions. So you must know like it is spontaneously or it is on ovulation induction, or if some like IVF, if we have given her IVF treatment and this conception is IVF, she is conceived by IVF, then there is increased risk of twin pregnancy, of having anomalous baby, with having GDM, having polyhydramnios. So these are the risks associated with the spontaneous or induced IVF conception. So second thing we have to ask is first antenatal visit date. Like when was her first ANC visit, if it was in the first trimester or not, on folic acid she had taken or not, routine antenatal test. So what are the routine antenatal tests? You must know these things. Routine will include your CBC, blood grouping, your all that serological test, which is HIV, HBsAg, HCV, and VDRL, and TSH, and RBS, FBS, or HbA1c. Okay. So these you should know to rule out the overt diabetes, that is pre-gestational diabetes, from the gestational induced diabetes mellitus. Okay, so these are the routine antenatal tests which we are offering to the patient. Now the third thing you will ask in your first trimester for the dating scan, anti-scan, and the dual marker. Any risk factor told to have, like was she told to have any risk factor, or like age related risk factor, or she's a known case of any kidney disease or heart disease or liver disease. Okay. And any history of any bleeding, UTI, hyperemesis, radiation exposure, teratogenic drug exposure, and history of any fever with rash. These are the basic things you have to ask in her first trimester history. Now the second thing is second trimester. So in second trimester you will ask iron calcium supplementation. Okay, so iron calcium supplementation or any multivitamin intake, routine pregnancy immunization like 2 doses of tetanus, diphtheria, like toxoid she had taken or not, that you have to ask. Mainly these are taken at a gap of 28 weeks, and if her second pregnancy is within the 3 years of the first pregnancy, then only required is a one booster dose, which usually she will take in her fourth month, or like in a second trimester. After mainly we are avoiding the first trimester these immunizations. So third thing you'll ask is quickening. So first is iron calcium supplementation, multivitamin intake, routine pregnancy immunization, quickening, first fetal movement when she noticed that in multigravida it is at 18 weeker, in primigravida it is at 20 weeker. Then anomaly scan that you have to ask, anomaly scan which usually we offer to the patient in 18 to 20 weeker, that you have to ask. If she had undergone any quad marker test or anything. So here I want to discuss with you some basic thing like the dual marker and a quad marker. The dual marker will include beta HCG, measurement of beta HCG, and PAP A measurement. And the okay, so and the this quad marker which we are offering to the patient at 16 to 22 weeks will include beta HCG measurement, alpha fetoprotein measurement, unconjugated estriol, and inhibin A. So remember A, this is not B. Okay. So anomaly scan, then quad marker, OGTT. OGTT we are offering to the patient mainly Indian guidelines, DIPSI is there, international guideline, IADPSD is there. We are offering at 24 to 28 weeks. DIPSI is a single step screening test. Then we have to ask patient any history of abdominal pain, bleeding PV, leaking PV, any fever, UTI, or any like raised BP problem, that we have to ask. In the third trimester, we'll ask iron calcium supplementation she took or not, history of any abdominal pain, bleeding PV, leaking PV, and fever, UTI, raised BP, or any other abnormality. Fetal movements, if she is perceiving, appreciating fetal movements or not, growth scan or any abnormalities which she knows, or anyone had told her about the any like growth scan abnormality. So after then we'll take for the past obstetric history, but before taking and before going to the past obs history, let's discuss from the starting. First, identification details you have to ask, followed by the parity index, followed by the LMP, EDD, POG, followed by chief complaints, history of presenting illness, history of present pregnancy including the first trimester, second trimester, and third trimester. Then we will ask her the past ops history. So if any previous para is there, then how long back was her delivery, any associated antenatal risk factor, any placenta previa, is it preterm or postterm, malpresentation, IUGR or macrosomia. Then we'll ask for the mode of delivery like vaginal, then induced or spontaneous C-section. Then we'll ask for indication of C-section, is it instrumental, forceps or vacuum delivery, any intrapartum and postpartum complications are there, how is the baby now, alive or dead, or maybe stillbirth that time. So that all the history we should take for with the patient. Then contraceptive history is also important, because like OCP or intrauterine device or copper T, whatever she used, it will influence the decision of contraception post delivery. So the contraceptive history is important, like any complications after inserting IUDs or after taking OCP pills, that will influence her decision post delivery. So we have to ask this. Then if previous any abortion history is there, then how long back it was, period of gestation, it is in a mid trimester or first trimester, we have to decide, because mid trimester mainly associated with the cervical insufficiency or uterine anomalies, or if it is in the first trimester, mainly having some congenital aberrations and all like that. And instrumentation, mainly like spontaneously her this abortion is spontaneous or induced. If induced, then it is followed by DNC or not. Or post abortion, if any workup are there, and post abortal any complications, that we have to ask to a patient. Then the menstrual history is previous menstrual history, her previous menstrual history was regular or not, because at least 3 previous regular menstruation we will take to rely on LMP. Or if it is not there, if it is irregular, then we'll rely on the dating scan for the our corrected EDD. And any previous history of any hormonal contraception, like, because if OCP she is taking in the past, then it will inhibit the ovulation, so will not rely on the dates. Her LMP will rely on the dating scan for EDD. Then again, history of menorrhagia is important because it will lead to anemia. Then past medical history, past surgical history, these are important. Past medical history include any chronic condition, chronic illness like hypertension, diabetes, asthma, any thyroid medication she is taking or not, like that we have to ask. Surgical history will include like history of uh, any myomectomies, or any appendicectomy, any cholecystectomy type of surgical history she has. Then it will affect the operative outcome, because the intraoperative we will find some additions. Family history is important to ask. Genetic diseases, history of preeclampsia in patient mother, history of hypertension, diabetes in the first degree family relatives. Then dietary history, if your time permits to ask for the dietary history, you can ask. If not, then it's okay, you can avoid this, because like increase intake of caffeine will affect the child. So that's why you have to ask about her dietary history and counsel her regarding that. Personal history can influence the pregnancy outcomes, like bowel bladder habits, alcohol, smoking, sleep, all you have to ask to the patient. So basically, you should learn this history taking in a proper format, so that you will not be forget that any points, and will take in a better way. Okay, next I will cover the history taking for like anemia, case presentation, and preeclampsia, and more. Thank you.